So welcome panelists once again, and as you may have noted, as you might have noted, we are from a little different domain related to medical, and two colleagues from Apollo Hospital, one colleague Mr. Zate, who is in pharma, and two more from medical device industries. So for this discussion, before we actually start more deep diving, I just want to take a brief note about how quality function has contributed to the growth of industry and as well as rise in India. Right, last 30 years has been like phenomenal for all of us. It's not just for this industry, and the growth that we have achieved, the recognition that we have achieved for our brands, our organizations across the globe, is I think primarily as well because of the contribution of each of you in the hall, right? The quality people. And this is a significant achievement for all of us. And because of the quality policies, regulations, audits, certifications, etc., this we could have achieved. And this is not the, probably a milestone for us to stop, but going forward from here. As Ms. Bhatia noted, that India has arrived, right? We are experiencing that, and the quality function is also transforming, not just with the tech and regulations. We are also, incorporating technologies and things like an AI hub. So, big round of applause for all of us in the room for contributing to this journey and helping the industries grow and humanity benefit. With this intro, I would have my first question to Mr. Sanjay about the patient being the the beneficiary of whatever we do. He's from pharma, he's from hospitals, and whatever we do is ultimately benefiting an end user, the patient. So how he is experiencing the transformation from the hospital quality department point of view, and what are his experiences and views on this point?
Thank you so much. It's lovely to be here today, amongst the pioneers and veterans of quality from various industries. So I come from an organization which is, very well known for, the clinical outcomes. So Apollo Hospital has been in operations since very long time, and I'm sure you might have heard and you might have probably availed the services of the Apollo Hospital as well. So what makes the hospital different from other organizations or the industry? Because we deal with patients directly. Whatever pharma, whatever other technology organizations or other industries would be working upon, so they directly or indirectly, they converge to the hospital where we deliver the services to the patients directly. So this makes this industry unique, in that way. Now, in the recent times, we also see a lot of transformation into the way we deliver the healthcare, especially after the COVID, and then we all have learned what is the importance of health and healthcare. So we also have seen a lot of changes and changes into the dynamics, into the way the patients would receive the healthcare and the providers they would provide the healthcare. So now it is not the simple time where a patient would come into the hospital and then a doctor would just treat. So there are a lot of dynamics which will come into play, which will make the quality of healthcare a bit complex as well. So if we talk about the basics of the healthcare, the health promotion and health prevention has always remained and probably will remain forever at the forefront of everything that we do. But at the same time, when it comes to the delivery of the healthcare, so now the patients are different. Also, the way they perceive the healthcare is also different. Also, the way we are delivering the healthcare by the doctors, by the nurses, by the healthcare providers in the hospital are different. The patients are more aware, they are more learned, they are more tech savvy, and they also demand healthcare in a very specific manner. The communication and coordination is the key. So earlier, there used to be a doctor and patient was the passive recipient of the healthcare. But now I think the patients are at the forefront. So they are the active partner of the healthcare which they are receiving. So they have a lot of say into the treatment options, the care plan that the doctor would define or the make for them. Even before coming to the hospital, they will see what are the doctors who are available, what are their credentials, what are their training level, what is the kind of experience he or she has, who will treat me. So he is more aware about the oral context. Also, thanks to the Google and other search engines, people are half doctors now, and they know about the symptoms, they know about the disease and probably the diagnosis as well. But many times it may not be so correct. That's why we need hospital and doctors to correctly diagnose them. But this really makes patient enabled, and they really make a patient partner into their own care. Also, when it comes to the treatment cost or the affordability, so there are a lot of dynamics. But being the public health matter, we will not go into the insurance and affordability and those kind of subjects. But another thing which I really want to dwell is about the patient engagement. So how the patients are more engaged now. So it's not only patient who will require to be engaged, but it is also the hospital who are making the patients engaged now into the care processes. Right from the consultation or right from the admission, now patients are being told what exactly it is going to be. What is going to be the charge, who is going to be the doctor, who is going to take care of your health, who is going to be doing the surgery, and how the entire treatment is going to be happening. Now patients will have a lot of questions to be answered. So patient would require a lot of counseling and hand-holding at various level of the care that he or she would be receiving. So it's not just the passive thing that patient would just be treated into the hospital. There are a lot of disputes. There are a lot of conflicts which will also happen into the hospital because of the unsafe care. Now quality, like in earlier session, they were asking about the quality in one word in various industries. So in healthcare or in the hospital, I would say the quality is nothing but the patient safety. But hospital being utterly unsafe place, there would be a lot of situations, contexts where there would be unsafe situations. There could be medication error, there could be hospital acquired infections, there could be anesthesia related complications, there would be some unanticipated clinical thing that could happen with the patient. So how this will affect the patient care, how this will affect the patient's outcome, and how this will affect the entire continuum of the care that the patient will be receiving, that is, I think, is the deterministic of the quality into the hospital nowadays. Thank you so much.
Thank you, Mr. Sanjay. I'll turn to now Mr. Sheikh about how he is ensuring the practices from the hospitals about safety and the patient care. What are the specialities or what are the practices that we have?
Thank you very much, Mr. Anand. Good afternoon, everyone, and it's a privilege to speak in front of diverse colleagues from different industries and who understand the language of quality. So, when you talk about quality in hospitals, it's sometimes difficult to explain because people understand quality, don't understand quality in hospitals. If they ask us what do you do in hospitals as part of quality, because they understand a doctor who is coming prescribing drugs and nurse administering it, I'm getting well and going out of the hospital. That's it. They don't understand the fine prints or the dynamics, how the hospital works. So as I'm looking to the hospital quality per se, so I would say the major elements which are important are the clinical outcomes, patient experience, and operational excellence, definitely. And one of it is patient safety. When I talk about patient safety, we need to understand, before that, let's talk about how healthcare or hospital is different from the quality in other industries. Dr. Sanjay has touched based upon that, but other industries definitely are focusing on the operational excellence, product or service. What hospital is adding is patient safety and patient outcomes. So when we say patient safety, so what is patient safety? So I'll just pop a question. So how many of you feel that if, God forbid, if you get admitted tomorrow in a hospital, and how many of you feel that if you are getting admitted for maybe a small illness or something, that you are safe, then you will get treated in 2 days' time and come back? How many of you feel that?
I'll share my experience. I'll share my experience. So I got hospitalized in Singapore versus I got hospitalized in. So I would say that we have a lot of work to do in terms of. So I got hospitalized in Singapore versus I got hospitalized in India. So I would say in India, I think we got to catch up a lot in terms of either processes or the entire transparency of the entire medical practices, or ensuring patient safety, security, and even the trustworthiness, I mean, that is yet to come. So this is my 2 cents.
Thank you.
But you know, on the brighter side, we also have come a very long way. If you look at the
Yes.
healthcare and the hospitals 10, 15, 20 years before and now what they have been. And thanks to all the national as well as international accreditation systems, like we have NABH, which also talks about a lot of transparency, ethics, also the evidence-based and scientific protocols that we have to, abide by. So, this also has given a lot of boost to the quality of hospitals and healthcare nowadays. But surely there is a long way to, catch up with.
Absolutely. Absolutely.
Thank you for adding on to that. So I'll just throw some numbers. So worldwide, as per WHO, there are around 134 million adverse events experienced by patients in lower and middle income countries. So India is a lower middle income country. You can understand the gravity. When you talk about high income countries, 10 to 12% of the patient experience adverse events. So that is 1 in every 10 patients experience some kind of adverse event. And out of these, 2.6 million patients die due to adverse events. We will not even come to know. So this is what is the gravity of errors and problems what healthcare industry is facing. So majority of these events are related to hospital-acquired infections, medication errors, wrong diagnosis, even a simple thing as communications. So to give you a small perspective, there is one parameter which is measured and is said that if you follow that, you will reduce the hospital-acquired infections up to 50%. It's nothing but a simple hand hygiene. We have washed our hands all through the COVID, I suppose, and there is a method to do it. What do you think is the compliance levels in hospitals? So if we talk about general areas in the hospitals like wards and other areas, it's just 50%. And in critical care areas, it is 60%. So we have a long way to go. Until and unless we improve the small metrics, we will not be able to achieve these things. And to add on to this, one patient who's getting admitted in a hospital will at least meet 25 to 30 different healthcare workers in a day. Starting from a security person at the gate to a receptionist, the person who's admitting the patient, who is counseling the patients, a consultant who's coming in, different nurses coming at different shifts, junior doctors probably, housekeeper, F&B staff. You can name a lot of people who are coming and meeting the patients. So you can understand if half of them do not wash their hands half of the times, so where you are, at what risk you are sitting and standing. So I don't want to make you afraid and simply I don't want to you don't get into a hospital and get treated for whatever illness you have. It was just to give a perspective. So what is the strategy, what we are doing? So at Apollo we develop a robust quality management program. So this program has different verticals. When I say verticals, it is all interrelated. For example, we have an infection control program, we have a medication management program, we have a program looking into the safety aspects, we have programs looking into other aspects like antimicrobial stewardship, which is part of medication management and infection control, but it in itself is a big issue. I think the pharma colleagues might definitely understand where we are in terms of antimicrobial resistance, and world is going into a darker place if we don't stop that evil. So what does these verticals do? And it is all, so quality program is an umbrella under which all these things come into play. So infection control looks into various aspects. For example, they look into the hospital-acquired infections, like how many patients who are undergoing surgery are getting infected, how many number of patients who are being put on catheters getting infected, what kind of hand hygiene compliance we have, how are we faring with a positive and negative pressure rooms, and how are we maintaining the pressures, how are we maintaining the sterility of an operation theatre. So all these things come under the infection control program. When we talk about medication management and medication safety program, we look into aspects like the way we select a medication, starting from a selection of medication and making it part of our hospital drug formulary, how we procure it, how do we store it, how do we indent it, how do we prescribe it, how do we prepare it, how do we administer it, how do we monitor it. All these aspects are looked into. Like this, so every vertical works in its own ways and help the hospital to achieve certain quality levels. So apart from these different verticals, we have to have a robust training mechanism. Healthcare is a human intensive industry. Equipments are definitely there, but they are not replacing human beings as of now, definitely. But it's complementing their work, helping in diagnosis and supporting other activities. So training plays a very vital role. So whenever a staff gets onboarded, there are different and various categories of staff working in the hospital. So everybody has a role to play in all aspects. So there is a curated training programs goes into play. For example, the nurses who are onboarded in our Apollo system gets trained at least for 20-25 days before they are deployed in the wards to take care of a patient. So the training might involve a lot of things, starting from understanding what is a hospital and how we function, what are our protocols and policies, and how we act or react to certain things. What are our clinical pathways and protocols? How do we manage a certain patient? In what ways? What is the step-by-step things what we take to achieve a certain clinical outcome? So all these things are trained. The other big aspect is about credentials and privileges. You might have heard very recently there is a doctor who was caught doing cardiac surgeries in one of the big hospitals here in Mumbai, right? I hope you might have heard it in news. So it is nothing but doing the background verification of a doctor. So we do have a robust mechanism whenever a doctor, not only a doctor, any staff who gets onboarded, we do background verifications. We try and understand what is his qualification, from where he has obtained it, what licenses he bears, whether it is updated or not, whether a nurse who is getting onboarded, whether she is properly trained, she is from the institute from where she is coming in, what kind of experience she has. The other aspect apart from credentialing is the privileging. Privileging is nothing but, for example, if there is a doctor who has joined in fresh, maybe a general surgeon, do we give him privilege to operate a patient with a robot or a laparoscopic set? The answer is no. We look into what kind of training the doctor has undergone, how many number of hours he has spent in operating or using those equipments. Based upon the previous experiences, we give the doctor to handle those equipments or devices, maybe independently or under supervision. So similar way, the nurses, for nurses we look into the competencies. So when we say competencies, it's about how efficiently or effectively a nurse is handling a certain procedure. If she can assist in a surgery, if she can mix a medication properly, if she can deliver a certain care or handle a specific population of patient. For example, there are pediatric population, not everybody can handle. There are neonates, there are geriatric population, there are adult women. So every age group, every type of population of patient has to be handled by us, but specifically trained staff. So these are the few things what we have implemented to ensure the quality factor in our hospital.
Thank you, Mr. That was very insightful for us. I'll turn to Mr. Zate now, who represents Pharma here, and I would like to bring attention to what Mr. Doshi said, like safety and efficacy of drugs and techniques. So when you brief more about your industry and the quality aspect, I would like to suggest you to talk about regulation. What is regulation for this domain? Because Mr. Sanjay also mentioned there are certain things,
thank you.
and is something more than the standards and the other things that we have.
My name is Dr. Prashant Zate. I am known to be in the industry, pharma industry, Dr. Zate. Everybody is calling me as a Dr. Zate actually, because I'll give my brief introduction. I am the member of the WHO, where the policy comes. I am the scientific advisor of the regulatory, the Food and Drug Administration US, and I am the various body I am representing. And whenever we are already recently went through the COVID pandemic. Basically, when such kind of the incidences happen, the pandemic is declared actually. The healthcare leader is coming in the front leader, always. Whenever this, as Anand has already, told me to give the brief about the regulations in the pharma industry. I belongs to the manufacturing of the pharma APIs and the drug products, where we are manufacturing some of the life-saving drugs, which is generally used in the some of the drugs which we are manufactured and formulated, which was used during the to save the life of during the COVID pandemic, and some of the drugs we are manufactured we are generally used to operate the cancer patients. While coming to the quality, and from the morning we are already listening about the quality and qualities actually. When the pharma industries comes, there is a three-dimensional qualities always will there actually. First is the quality control. Second is the quality assurance, and third is the regulatory affairs. What does mean? The quality control means whenever you are manufacturing any products or any drugs or drug products, you have to ensure that to meet, because in the pharma industry there is a no, you cannot write anything on your own way, because there is a guidance is already there. That called as ICH, actually International Council for Harmonization. Actually, you have to be bind for the everybody's actually the pharma, actually manufacturing. So once it is coming to the manufacturing activities, as I mentioned, it's a quality control. There is a books is written. It's called as we call it as the pharmacopoeias, where the states are already, it is already defined. So you need to be see whether actually what we are manufacturing the product, it is meeting the as per the standards. Then you have to be, after meeting the standards, you have to be give the assurance, yes, my product is right to use for the patients, and it can be supplied in the actually the hospitals. Third, whenever he is going for the actually, I am coming to the regulatory affairs. Regulatory affairs means you have to deal with the regulators like the US FDA, EMA, then like EDQMs and ANVISA, NMPA, China. All the regulations are already there actually. So we have to be deal with them. So you need to be prove yourself, your product is safe for their countries and your own countries actually. So the concept is like that actually, because as Mr. Vipul has already told that actually we have to be go to the passes through our product has to be passed through the respective stages actually. See, in our pharma industry always in the manufacturing we have to, there is no concept actually like tomorrow is inspector is coming, so you have to be ready for 24/7 actually. There is no concept actually is coming after the 1 month and you will be ready. You make your facility ready for inspection. That concept is not like that actually.
So it's a surprise audit.
It's always surprise. They are coming on the actually gate and they are saying actually I'm the inspector from this agency actually. I want to inspect your facility. So other things I am going to be touch base for the another actually there is a recently, because today's topics we are given as this conferences is challenges in the healthcare industry. So I am going to actually taking the what are the challenges we are facing every day. The new regulations, new guidelines are coming into the in place. I'll as a actually I have done my research in called as a genotoxicity. Genotoxicity I'll then go to the touch base. Genotoxicity means actually there are the many actually people they are consuming the drugs like actually throughout the life for the diabetics and the blood pressure. During the manufacturing, there are the certain chemicals has been used, and that can be retained in the actually drugs, which can be carried forward into your human body, and over the period, it can be generated in any form of the cancers. Basically, so that actually, so that is the regulation has been come called as the nitrosamine impurities and the genotoxic impurities. The level of these impurities you are not believe actually. The regulation has already given that is the ppb level, not in the even the ppm. If you are going for the actually the billions, actually you have to go for the actually one part of the ppb. It's the parts per billion we call as actually. So sometimes you are already seeing that actually the compliance of this such regulation is very difficult. So that time we are seeing that there is a shortage in the drugs in the market actually. Most of the people might be they are knowing is the drugs called as ranitidine, which is generally used for the actually acidity actually. But if you go and ask actually whether it is drugs is available, no. Because it's stopped because of the nitrosamine impurities actually, because it's a very cheap drug. So you can give the one pills of the 1 rupees actually. So this is actually shortage is coming in actually, and the other things I am giving, there is actually supply chain of the actually in the pharma industry is the main challenge nowadays actually we are facing. There is a drug called as oxytocin, which is generally used to prevent the miscarriages in the actually ladies actually. So what happened actually? This drug is very heat sensitive actually, and whenever we are not properly store the drugs, it might maybe get the degradation, and that efficacy has been we are losing the efficacy. The same case was happening in the Nigeria, because that country is actually called as a malaria prone countries, and whenever your drugs is not properly stored and the efficacy has gone. So such kind of the actually challenges we are facing, but yeah there is certain solutions are also there actually. WHO and UNICEF always giving the actually to promote such kind of the actually activities actually. They are investing for the low, as one of our panelists has already given the brief on that actually, the low income countries groups and the middle income actually. So they are fundings, and we are now the started actually I'll give the one of the examples and I'll stop actually, because everybody has already So the one of the concept actually like when there is during the COVID actually, when the vaccines has been already established, after that there is a main challenge how to supply these vaccines to actually remote places. because the current vaccines, whatever we are already defined, that require the storage of the 2 to 8 degrees. And some of the vaccines is required to be stored as a minus 20 degrees actually. So establishing each and every actually locations is very difficult. And because of that, almost 20 to 25% vaccine has been already waste actually. So that was one of the sad part of our pharma industry actually, because there is no proper infrastructure. So these are the challenges we are facing actually. You should be ready for the 24/7 for the inspections. Whatever the product you are manufacturing, that is compliance as per regulations. Either it's a new guidelines, whatever. Whenever we are going for the new, actually whenever you are registering your product, so that time what happened, by the getting an approval, the new regulation is coming actually. So again you have to spend another 2 years or the 3 years down the line actually. So it is very difficult to actually tackle this, but we have to be go through this process actually. Thank you.
Thank you, Mr.
We have one more challenges, that is a counterfeit medicine.
Yes.
Oh.
Recently,
Yes.
CGS has
WHO GMP.
around 40 medicines which is counterfeited.
Correct.
All the big brands which is counterfeited in the India.
Because everything is coming, the new list is coming in the newspaper actually. These are counterfeiting actually medicines actually, and it is very difficult to find this, whether it is a genuine or the the duplicate. It's very difficult. And because of that actually, the most of the actually our health industry is suffering.
So, how do you find these generic medicines nowadays are on peak? So, the quality and safety in that?
I'll actually probably go to the actually go for the branded one actually. The generic whatever.
That's a big challenge again.
Yeah, again, because whenever we are talking about the actually our Make in India concept, always they are looking for the 70 to 80% reduction in the prices actually. So that will be the more challenge, and actually we call it as a Bombay market. There is a call as a Bombay market actually. So always if you look about the Bombay market, always there is substandards, material will come in under the and whenever you are the branded one and the counterfeit medicines or the generic medicine, we will not find any differences in between that actually. It's very difficult to find.
Thank you, Mr. Dade.
Yeah.
I'll turn to
From
Dr.
point of view, have you done any comparison with the generic medicine versus the branded one?
Yeah, always, actually,
But the content would be same.
yeah, content will be same, but I have already given the overview on the impurity profiling actually. When we compare with the impurity profiling, it will be very difficult to match. Because, when we are going for the testing these impurities, actually you record the high-end instruments like the HRMS or LCMS, this kind of is very difficult because the costing is more
But
than
on
5 to 6
contrary,
crores.
government is promoting for that nowadays. We see.
Government come up with this.
Can we take this up during the lunch because other speakers have to also view. Can you say interesting, I know, but please hold your patience.
Thank you.
Thank you, Mr. Zade, and thank you for your patience as well. I'll turn to Dr. Muthu now. He's from Tricog Health, heading quality department, and he is representing the medical device, right? So I would invite his views on the challenges and as well as like how medical device industry is like evolving and dealing with the quality standards, the regulations, etc.
Thank you, Dr. Anand. So, good afternoon, everyone. My name is Muthu Dandapani. So, I work for a company called Tricog Health, Bangalore based. We are a mid-size MNC. So, I want to give an example of our own organization, how we are revolutionizing the digital health. People are talking about generative AI, artificial intelligence. So, I want to give a real-time example that what we have implemented in the 6 states of India. So, we work on ECG and echo analysis interpretation. So what we do, we have developed a software using the artificial intelligence and machine learning that can interpret the ECGs and echoes in 10 minutes and for echo 1 hour. So as a country, we are 1.45 billion population, but then the cardiologists, the number of cardiologists in our country, they are less than 4,000. And how we need actually 88,000 cardiologists, but what we have in our country is only 4,000. So how do we address the gap? Because the cardiac thing is a very serious condition. It cannot be waited. Like when a patient go to the OPD, when the echo is done, you cannot ask him to come for after 3 days. So we have to give it in a few hours. But then the cardiologists are very less. So there is a program. I think you all know in the 2021, Government of India has initiated National Health Digital Mission. In that, they have introduced all the digital technologies to come into the forefront. So we as a company, we deployed this in 6 different states, and then we are piloting now. We are able to save thousands of lives. So when the patient is identified with a critical condition, we will be calling them. We will be calling them to get admitted because we will be able to understand the 154 conditions of the heart.
So when you take the ECG, if a doctor looks at it, he may be able to identify 25 to 30 conditions. But then what we do, using the AI and ML, we will be able to go deeper, around 150 conditions, and then we'll be able to relocate the patient to the ICU ward to take the next course of action. So the digital health is evolving so that it can be the interoperability and then the integration happening from the hospital and clinics. So today we have around 8,000 hospitals. Most of the major hospitals use our technologies, and we are able to give the ECG echo interpretation to the last mile. So within 10 minutes, if the ECG is performed, we will be able to give the report to the doctor. We are not replacing the doctors. I am not saying that we are replacing cardiologists. What we are doing is we are helping the cardiologist to take a rational decision, and it's a clinical decision support tool. And as Dr. Anand said, it's a regulated industry. So we work in a regulated industry. It means we need to validate our model. The artificial intelligence that I use, I have to validate, I have to get a approval from the CDSCO, DCGI, US FDA. So all the software that we use are regulatory approved from the CDSCO, and we do all the checks before we release the software to the patients or doctors. So the patient uses the app, and then the doctor uses the dashboard. So by sitting in a home, the doctor will be able to see which patient of him is actually the vitals are going down and who needs the treatment. Because we work with the cardiac failure patient, they are very, we have to help them in the right time to get admitted to do any surgery or to save their medicine. So that's where we work on, and this is just one real-time example that I'm giving. But otherwise, now government is working on the national digital health standard. Yesterday we had a meeting with a lot of stakeholders, and the NABL is trying to gauge all the digital health standard, because a lot of hospitals use the EHR LIMS system. So how we can integrate them so that the patient, the diagnostic report is digitized, and then he or she can go to any hospital and continue with the treatment. So that's where the Government of India is moving towards the digitization of their thing. So you all know ABHA ID has been created. Now 70 crore people have ABHA ID, and then now doctors are registered in the ABDM portal, the clinics are registered. So we are all migrating towards the interoperability and integration. I'll stop here, maybe we'll continue later.
Thank you, Doctor. So I'll now turn to Dr. Chakrabarti. He presents Biomerieux. He's a French giant. He's also involved into medical device manufacturing. He's also representing a function government affairs. So I'll kind of request him to brief that as well, what is government affairs, for the benefit of audience, and share his perspective on quality and the challenges.
Thank you, and good afternoon everyone, and thanks that you pronounce my company's name correctly, because it's a French name. Many people say Biomerieux, but exactly it is Biomerieux. The X is
my daughter started learning French, and I recognize this is a French name. So thank to her.
So this is also advantage of talking later, because my fellow panelist has made my life easy, because we are sitting with the healthcare professionals like the hospitals, then we have got pharma, and then we have got medical devices. And among medical devices, I represent in vitro diagnostics, and I'll take a minute to explain what is in vitro diagnostics. 70% of the clinical decisions are based on the in vitro diagnostics or the diagnostic tests. So previously, the diagnostic tests was not that important, because the doctors was very knowledgeable, or they used to have the by touching the pulse, and they used to have their own wisdom, but now it's no more. Now doctors rely on getting the test results, and they take the decision, which is an informed decision. And over a period of time, the diagnostics and in vitro diagnostics has revolutionized, and especially post-COVID, the general population has been get more aware about the importance of tests. Everybody knows what is RT-PCR test, and everybody knows that health is important, and doing the preventive tests is very important. And in vitro diagnostics, especially in case of molecular diagnostics, has really helping the clinicians in real term that we do not have to wait for days or weeks to get a test results. There are technologies which is molecular syndromic technology, which is multiplexing, can do more than 25 to 30 different viruses, bacteria, antimicrobial genes, resistant genes in 1 hour. So when a patient comes critically ill, and then the doctor has to take a decision that which antibiotic will work, whether it's a viral infection, whether it's a bacterial infection, and which antibiotic will work. And these are golden times, and you cannot take the hit and trial that by giving the highest antibiotics, and then you wait for whether it's injectable, and then again we wait that whether the patient is responding or not. And that way you lose the patients, and many of you must have heard the sepsis. Most of the deaths in the hospitals, most of the deaths which has happened multi-organ failure are because of the sepsis. And the sepsis happens because the patient deteriorates very fast, because then multiple bacteria and then the antibiotics which is actually required does not respond because of the antimicrobial resistance. And what is antimicrobial resistance? I'll take a minute, because for last 10 years there are very few antibiotics has come into the market, because getting a new antibiotics requires $1 billion, and it requires a high regulatory pathway. It requires phase 0, 1, 2, 3, 4 trial. And by the time the new antibiotic comes, then the antibiotics has been given to the patients, and then the antibiotic resistance comes because of the pharma companies promotes it so vigorously that doctors prescribe it, and then many of the times the patient may or may not require it, and then they have the resistance. And the international statistics says by 2050 there could be more than 50 million deaths every year because of this antimicrobial resistance. Antimicrobial resistance is more than tuberculosis or more than HIV or any other infectious diseases. And what happens, especially in India, the situation is very alarming because of the misuse and the overuse of the antibiotics, because we have got very less regulations. Anybody can go to any chemist shop, and every chemist shop is a doctor. Every chemist is a doctor, and you can say that I have got cough and cold, and I need, and the chemist will give you antibiotics, which is, rather than going to a doctor by giving a fee and then going to get some test which will cost, we take this, we pop up these pills, and which is exactly not required, because common cold, cough and cold could be viral, and viral does not require antibiotic. And by taking these antibiotics, or many times we reproduce the old prescription and similar symptoms, we take the similar antibiotics, which is also not right. And then the cost of the antibiotics in India is also not that high in compared to US or Europe, and it's easily available, and then we have the resistance. And also in hospitals also, because of the hospital's acquired infection, you go and admit to a hospital ICU, and the hospital ICU has got different patients which are having different diseases. And someone might be having a pseudomonas, something like Neisseria, and then you have gone and for some diagnosis or some condition, and you get the bacteria which is not for the treatment, but because you were in that environment, so which is called hospital acquired infection, and then you go for one treatment, you get another disease. So that's also another hazard. So antimicrobial resistance, antimicrobial stewardships are very important, and it's not only the the pharmaceuticals companies, because it's also with the poultry, because we use the antibiotics to the animals, and then we take it's in the ecosystem. We take the either the poultry product or for food products or for the meats, and then we consume it, and then it goes into the soil and in the water, and its own health. It's not only the animal environment and the ecosystem. So it's a very complex. And in India, of late, the awareness on antimicrobial resistance, sepsis, has been increased, but still we have long way to go, because we have policies. Indian Council of Medical Research has got policies on the national antibiotic policy. There are a lot of focus from Directorate General of Health Services, and hospitals like Apollo, Medanta, everybody, they have got their own internal antimicrobial resistance AMR group. They have got prescription audit. So a lot of things are there, but still in rural areas, still in villages, the use of the diagnostics tests are very limited, and still these laboratories, not all laboratories are been registered. There is a NABL accreditation is there, but still it's voluntary. You do not know that you give a blood samples, where it goes, which lab it does, whether this report is been generated, who signs it. So there are a lot of things, and since this is an industry which is a highly profitable industry, and all big players has now come, Tata, even few days back Amazon has also introduced that they can.
Sorry to interrupt, Dr. Chakravarti. So we are just given a warning of time up. Okay. So let's open up for audience for a couple of questions that may have. I may start with you. I interrupted your earlier question.
No. Basically, I was asking you why cannot government has checks and balances to ensure that we don't have the secure medicines, safe and secure medicines, even if it comes to generic medicines.
It's a good question actually. So basically, government has policies to go for the to get the secure medicines to everybody. For that, actually, CDSO is taking care. Our central, drug and controlling governing body actually, and simultaneously DCJ is also coming into in place actually. So whenever we are coming to actually and simultaneously state level, FDA is also involving actually. They are frequently visiting and finding out actually, as one of my colleague is already mentioned. There is actually counterfeit is going on. Actually, they are capturing, they are sending for the testings, and simultaneously they are closing the medical shops, even the factories as well actually. So these are the actions are going on the back of the in our industry actually. So this is definitely the government is taking the initiatives.
I just try to add one point here. To addition to that, government also last budget they established centralized lab across the group of states. Maybe in the East Zone and West Zone, and Mumbai also once testing lab is there, and Calcutta testing lab is
it's called as CDDL.
So that lab is taking care for the generic medicine counterfeit issue. So however, that perspective, what exactly I said is not a Bombay market, is government come with some innovation. Today also US, Donald Trump say, I want less cost medicine.
Yeah, Trump tariff, we call it the Trump tariff. We call it the Trump tariff.
Yeah.
Because that is a major issue now the industries has been facing.
One more question please.
I have only the last question.
One question from here.
And this is with reference to circular economy, right? Generally at the medical store, not many drugs got expired. What do, as a manufacturer, what's the responsibility of you guys?
No, whenever actually the medicines before 3 months expiry, that has to be sent back to the company. Then company has rights to destroy in-house actually there is a facilities, and that will be, we have to be show this much medicines we are already received inside, this much is to destroy. All the records are already there in the each and every manufacturing companies. So we can go and we can verify that.
Yeah.
So in order to, yeah,
is this happening in the field?
yes, it's happening.
Actually, in order to provide good quality health for 150 crore people, what are the capacity additions, the effort which whether hospital or other people they are doing
the physical capacity addition and also the competency capacity additions.
Mr. Sanjay, you want to take this?
So at a government level, there are a lot of the capacity building programs, not only for the patient in hospital, but also at the competency level. So they also have gone into a lot of remote areas, peripheral areas where there was no access to medical care or health care. But now through the enhanced the National Health Mission, I think they have approached to a lot of such peripheral area where there was no existence of healthcare. So in terms of that rural gap that was existent before, I think government has done a lot of things. Also at a city level or the urban areas, they have put up a lot of additional beds into the government hospitals, civil hospitals. They also have opened up new hospitals. They also have gone to PPP models where they have adopted some of the private hospital, and private hospitals have also been told to look after the patients who are going to the government facility. So that way there is a lot of boost which has been given by the government. But still there are a lot of areas where because of the inherent issues there is no much of healthcare. It may be because of the socio-economical factors, it may be because of the geographical limitations, it may be because of the cultural factors. So there could be some limitations, but I think there is a lot of work which has been which has gone in to the capacity building. And also at the competency building in terms of the skill level of nurses and doctors, and also the paramedics, how they have been they could be improved. So there are a lot of government programs which are running to impart a lot of life-saving skills to people, especially to the ambulance drivers, paramedics who are working into such peripheral areas where there are no doctors. Also the nurses who are manning some primary health centers and some of the areas where there is no doctors. So a lot of such things which are happening. A lot of even corporate and private players are also putting in a lot of efforts to give training, skill-based training to government people, especially the Tata, who has also worked a lot of initiatives to give skill to such people who are working into remote areas without any much of clinical support.
Thank you, Mr. Sanjay.
Thank you very much, ladies and gentlemen. Please give them a round of applause.